Um, yes, thank you. And for recording, y'all, if you do not want your likeness shared in the video, please keep your monitors off. The video will be made available to people who aren't able to attend tonight on our YouTube channel and to members. So just to put that disclaimer out there first. So let's dig in. Again, good evening, good afternoon to our beloveds on the West Coast, and welcome to COTAD Conversations, Abortion, Advocacy, and Healthcare, and Interdisciplinary Discussion. My name is Dr. Kalia Johnson. I am an occupational therapy practitioner. I'm an assistant professor of occupational science and occupational therapy at UNC Chapel Hill. I'm a COTAD board member, co-chair of COTAD Engage, and your moderator for this evening. We appreciate you all spending your evening with us and engaging in this conversation. We are not here to silence any voices, so please feel free to use the chat, and Whitney will share a little bit more about that and housekeeping in just a bit. But now I'm going to turn it over to COTAD Chair, Dr. Arame Enverizade, to tell you a little bit more about COTAD. And after you hear from her, you'll hear from COTAD Engage Co-Chair Whitney Harris, who will review tonight's objectives and housekeeping.
Awesome, awesome. Thank you. Thank you. Welcome, everyone. Thank you, Dr. Johnson, for an incredible welcome and for moderating this important discussion this evening. So I love sharing the COTAD history, but today I've been instructed to just give you a brief overview of who we are and what we represent. COTAD is a coalition. It's a coalition that was developed through grassroots organizing almost, I can't believe it, 10 years ago, because a few of us saw a desperate need to address the lack of diversity in OT, as well as focus on increasing health equity. And from a group of emerging leaders, we have developed a remarkable international premier organization focused on empowering OT practitioners, not just leaders, but everyone, to engage in practices that increase justice, equity, diversity, and inclusion, which we call JEDI, anti-racism and anti-oppression. So we're beyond JEDI for a transformative OT profession. And we believe that there will be a future in which occupational therapy is accessible, inclusive, and effective for all. And because we have the most amazing leadership, as you see from our welcome, and membership, as you see from the individuals, all of you participating, I truly believe we as an organization, as a community, as a coalition, will continue to make a powerful impact in this work while also being the change that we want to see. And we organize and actualize our outcomes through different committees, such as COTAD Ed, which supports our mission in academia, through COTAD chapters, woo-woo chapters, I know I see some of you are all here, which supports it through students who, might I add, they are phenomenal and they are our future. And through COTAD practitioners, which supports our mission in the workforce and emphasizes the power of mentorship, as well as through COTAD Engage, which is the committee who organized this event today. I am excited to announce that we will be having a 10-year anniversary next year. I can't believe it and can't wait to have all of you a part of the celebration. We will continue to host events, activities, discussions, and more. Thank you. Thank you all for being a part of our growing organization, and most importantly, for being part of history. So I'll pass it over to Ms. Whitney Harris, who is, I have to brag about this, who is our first ever COTAD chapter chair. And now as a practitioner, she is a COTAD Engage co-chair, and she will share what our session objectives are all about. Thank you again for coming.
Thank you, Dr. A. Yes, we have our special relationship. She was my professor in OT school, and we were able to collaborate to make what is now COTAD chapters, and so proud of that. But anyway, staying focused here. So the objectives for tonight. We will first summarize, well, yeah, there's these three here that are the primary focus for tonight. So summarizing the key points or components of the Dobbs versus Jackson Women's Health Organization. We'll describe the impacts of the reversal on healthcare services and delivery, and identify avenues for professional and interprofessional advocacy. So different ways that we can help our clients. Very good. And so a little bit of housekeeping, and community rules. So just to keep this a safe space for everyone, please mute your mic until the Q&A. We'll open that up for questions. But use the chat feature to ask questions and engage during the conversation tonight. It'll be great to just interact in both ways, listening in, but also in the chat as well. When you are speaking or sharing or asking questions, please use I statements. Remember that everyone has their own truth, and move forward and move back, meaning allowing space for others to finish their thoughts before speaking up or sharing. Discuss the issue or topic and not the person. And let's really maintain mutual respect for everyone's experiences and reflections. And remember, we are all here learning.
Thank you, Dr. Amberizadeh and Whitney, for sharing the history, but also keeping it real on how we want to create space for dialogue tonight with this event. But y'all, I am pleased to introduce tonight's panelists. With us is Dr. Tracy Wilkinson, Ms. LaShondra L. Russell, Dr. Veronica Vernon, and Dr. Victoria Garcia Wilburn. So Dr. Wilkinson is a general pediatrician and health services researcher who currently works at Indiana University. She completed her general pediatrics fellowship at Boston Medical Center, where she began conducting research on access to emergency contraception for adolescents. Her research was cited in the federal court case that removed age restrictions for emergency contraception access. After her fellowship, she was in California for 3 years, where she worked as a primary care clinician at Children's Hospital of Los Angeles. She relocated in 2015 to the Midwest to focus more on her research at Indiana, and has a K-23 grant from the National Institute of Child Health and Human Development. Her research interests focus on reproductive health care access from the perspective of general pediatrics and using human-centered design approaches. Dr. Wilkinson is a current board member for Physicians for Reproductive Health, a national physician advocacy organization and healthcare education and training, a regional organization dedicated to reproductive health education and training. She is also a member of the Oral Contraception Over-the-Counter Working Group. Ms. LaShondra L. Russell is a licensed OT and owner of Occupational Transitions, LLC, a mobile clinic in Virginia specializing in conservative management of pelvic floor dysfunction and lactation and breastfeeding care management for mothers in the up to 1 year postpartum period. L holds certifications as a postnatal yoga instructor, educator of infant massage, and pregnancy and postpartum core exercise specialist. L is completing training to obtain both her PSI, PMHC, and IBCLC credentials, seeking innovative ways to serve mothers through her Grounded and Rooted in Motherhood program, including launching her 2023 project that will research the use of wearable technology for improving maternal health outcomes. Dr. Veronica Vernon is a pharmacist and assistant professor of pharmacy practice at Butler University. After her residency training, she started her pharmacy career as a specialist in gynecology at Veteran Health Indiana, focusing on providing high-quality, team-based care to women and gender-diverse veterans. She teaches reproductive healthcare topics to pharmacy students and physician assistant students, in addition to training providers across the country in the VA system. She has worked on legislative efforts to expand contraceptive access for the past several years with several other stakeholders in Indiana, and is the current president of the Indiana Pharmacy Association. She is also involved in advocacy efforts through the American College of Clinical Pharmacy, American Pharmacists Association, and American Society of Health System Pharmacists. And last and certainly not least, Dr. Garcia Wilburn, who is an assistant professor of occupational therapy in the School of Health and Human Services at Indiana University. She is a community engaged researcher, partnering with community organizations to help solve pressing issues that impact Central Indiana residents, focusing on justice. She is an advocate for promoting state and federal policies that advance health equity and occupational therapy practice. She is the 2022 recipient of the American Occupational Therapy Foundation Intervention Research Award, named Outstanding Woman Leader from the Office of Women at Indiana University in 2021. She is a fellow of the American Occupational Therapy Association and serves on the board of directors for the AOTA and Hope Academy Recovery High School, the only high school in Indiana that supports teens in recovery. She is committed to improving the quality of life of all persons and is running a positive political campaign for Indiana State Office, her newest leadership endeavor.
The Supreme Court has overturned Roe v. Wade, the 1973 decision that established a constitutional right to an abortion in the U.S. Now, decisions on the legality of abortion are left to the states.
This is going to mean that access to abortion will vary dramatically depending on where you live.
While 16 states and the District of Columbia have laws that protect the right to an abortion, 22 states have laws that could ban all or most abortions now that Roe has been reversed, according to the Guttmacher Institute, a policy group that supports abortion rights and tracks national abortion statistics. The organization details a patchwork of laws among these states, including pre-Roe bans, trigger laws, and post-Roe restrictions that will determine the fate of abortion access in the U.S. 9 states have bans on their books that predate Roe v. Wade, which have been unenforceable for the past 5 decades.
Some of them date back to the late 1800s or early 1900s. These could be laws that could be enforced after this decision or as a result of this decision.
States like Arkansas can now revive their pre-Roe bans through official enforcement or by filing court actions. However, not all states with pre-Roe bans are poised to enforce the laws. Michigan Governor Gretchen Whitmer and abortion rights groups have filed lawsuits to block the state's 1931 law that makes providing an abortion at any point during pregnancy a felony. A Michigan judge, through a preliminary injunction, said the state can't enforce it.
Whereas others in states like Arizona, for example, I know lawmakers there are anticipating that they could enforce their own pre-Roe ban on abortion.
13 states have passed so-called trigger laws on the condition they would go into effect if the Supreme Court rescinded the constitutional right to abortion.
However, each of these laws are quite different from the other one.
And they can take effect at different times. In Kentucky, Louisiana, and South Dakota, the laws are enforceable immediately. But in Texas, Idaho, and Tennessee, there's a 30-day buffer period between Roe's reversal and when the laws go into effect. In some states, trigger laws can only be implemented after state government officials, such as attorneys general or governors, certify the high court's decision. Some states, including Georgia and Alabama, have sought to set stricter limits on when abortions can be performed during a pregnancy. Georgia's ban on abortion around when cardiac activity can be detected, and Alabama's near-total ban have previously been blocked in court because they conflicted with limits set by Roe.
Now the elimination of these federal protections for the procedure and the reversal of the Supreme Court precedent means that it's possible they can be resurrected in some way.
Some states don't have these specific restrictions or protections for abortion currently on the books, and it remains to be seen what actions they will take in the future. Meanwhile, abortion clinics in more liberal states have been preparing for an influx of patients.
They are expanding their hours, adding more staff, adding more days that they are available to accommodate what they expect to be even more patients coming in.
Abortion providers in more restrictive states are also assessing how to support patients who will need to travel outside of the state for the procedure.
planning and figuring out how they will navigate this different and varying access to abortion across this country will be something that I'm sure will take some time to really nail down and figure out.
Tragic, unfortunate, a return to righteousness, an erosion of privacy, supreme deceit. Today, abortion, what will it be tomorrow? I am a woman, not a womb. Abortion is healthcare. Roe overturned is God's will. Abortion is un-American. A sad day, a new day. No matter which side you fall on, it is landmark. These were the headlines that rolled across our television screens and over the airwaves. Memes became a way we coped with what seemed to be an impossible reality. We spent hours in discussion about our respective roles as practitioners, and colleagues took to their social media platforms to pin think pieces on the court ruling. American Occupational Therapy Association President Allison Stover stated, the U.S. Supreme Court's decision on Dobbs versus Jackson's Women's Health Organization ended federal rights that had been in place for nearly 50 years and shifted power on related healthcare policies to states. Occupational therapy was the first profession to identify sexual activity as an ADL, and we emphasize the value of this ADL in our scope of practice. Additionally, the OTPF4 obligates us to assist individuals, communities, and populations to develop and practice in meaningful and purposeful habits, routines, and roles. Our expertise in the dynamic relationship among person, occupation, and environment, along with our code of ethics, must guide how we navigate highly complex policy changes while supporting consumers' health, well-being, and participation. Our unique history, rooted in mental health, combined with our expert training in body functions and structures, creates an avenue for realizing the goals of each individual, as well as communities and populations. These significant changes to the policy landscape will change how we practice occupational therapy, while heightening the experiences of occupational and social injustices, disproportionately among women and those who identify as women first, with greater risk to continue to impact many other communities. We must be responsive and agile in order to survive and thrive as a profession, as a community, and as individuals with occupational beings. And I'm gonna stop sharing my screen so we can all see each other for this. But I want to start our conversation by first addressing our occupational therapy panelists. To begin our conversation this evening by reflecting on these words from AOTA President and discuss how and why occupational therapy is implicated in the Dobbs versus Jackson ruling.
So I will assume that that question is directed to me and my other OT colleague here. So as a community worker who has had experience, particularly in working with mothers in the criminal justice system, that was the first direction that my mind went to, right? Because I am working with these mothers who are in the criminal justice systems because they've had challenges on how to manage or how to deal with stressful situations in their life. And for some, that also included pregnancy. And with that, as I was doing my research and just looking at what got them into the criminal justice system, for a majority of them, it definitely was nonviolent activity, whether it be, drug sales, whether it be theft. And so as I'm thinking about the moms that I have worked with in the past and potentially moms whom I will work with in the future, and looking at recidivism rates, if this, going forward and, depending on what state they're in, I'm in Virginia, and looking at the bans, just thinking of how that's going to perpetuate some of that behavior. How is that going to continue to put them at risk of remaining within the criminal justice system. And so that was one of the concerns that I had in terms of working with moms there, like how do we kind of use this and navigate around that pipeline, you know, especially when our goal is to assist them back on community reintegration, and also looking at that, how is that also going to change prenatal care utilization? You know, while there are certainly other options out there, you know, should a mom decide to bring a pregnancy to term, there is something that happens, I think, innate in all of us when we feel like a choice has been taken away. We don't always think about those other options, viable options that may be available. And so I started thinking about how is this going to reduce prenatal care utilization, which is also going to in turn increase the risk of premature births, particularly for those who are practicing in NICU, who are practicing out in early intervention, who are practicing out in outpatient peds. So I can certainly see an increase in our caseload there, which is already a stressed waiting list when it comes to service availability. And then just an increase in maternal mental health. And so that is just something I am still just trying to grapple and wrap my head around, and just thinking of ways that we can support those who identify as women, those who identify as mothers, or just those who have birthing bodies who feel like that choice has been taken away from them. And regardless of what our own personal beliefs, as you mentioned, Kalila, our ethics is to provide social justice, to support social justice. And so if I have a mom who comes to me with this concern, you know, I consider it my duty and the ethical right to provide her with this information, you know, along with other, again, viable options, as well as the support of speaking with her healthcare provider. So this is definitely something that has been challenging, to say the least, in my own clinical practice, as I mentioned, especially when I'm already working with an at-risk community. And one of our goals, again, is to reduce that recidivism rate and also assist them with community integration. And I can certainly see this being a barrier. And so I have been connecting and reaching out with other practitioners on just innovative ways in which we can support these individuals, and identifying what supports can we put into place as we all kind of navigate this system, whether it be through our own personal experiences and or our experiences as a practitioner that is supporting this population.
All right, thank you so much for sharing that, Dr. Wilbur.
Yes, I think, you know, I've been speaking about this issue a lot lately, especially at the doors when I'm engaging with voters. And what's really problematic about this is that I think majority of people have an idea of who accesses an abortion and why they might come to that decision. The reality is persons that can have children come to abortion for a variety of reasons. And I particularly want to use this example, and I do want to provide a trigger warning for this example. I think about the case that we had come to Indiana that made national headlines of a 10-year-old girl who needed an abortion because she was a victim of rape. That 10-year-old girl, per our occupational therapy code of ethics and practice and guidelines, had she been forced to carry a child, would not have been able to participate in her favorite occupations, like play, like going to school, like being a member of her family. And so those are really, you know, we can't forget that abortion involves those instances as well. And so it is our duty to advocate for the most marginalized among our communities. And those are persons that are victims of rape and incest and molestation. And with these extreme bans, it allows for very little leeway. In Indiana, it was proposed that a person who experienced rape, incest, or molestation had up to 12 weeks to get an abortion. I have 2 adolescent daughters with very irregular cycles. They would not even be aware that they were pregnant by 12 weeks in order to make a decision So we have to really understand the complexities of this and how it impacts our profession in a variety of ways, which is why the most common sense solution is to remain having abortion as healthcare and having an abortion decision be made between a healthcare provider and the patient.
Thank you both for sharing that. And if we have any occupational therapy practitioners on the call who also work with families or work in the criminal justice system who can also weigh in on this, please share that in the chat if you feel comfortable doing so. Now, speaking of adolescents, the American Academy of Pediatrics, which includes approximately 67,000 primary care pediatricians, pediatric medical subspecialists, and pediatric surgical specialists, reaffirmed their support of adolescents' right to access comprehensive, evidence-based reproductive healthcare services, including abortion. The AAP also reemphasized their support of their member chapters as states consider policies affecting access to abortion care and supporting their pediatricians in their care for their patients. Now, Dr. Wilkinson, some of our guests may be wondering how and why Dobbs versus Jackson is important to the AAP and pediatrics in general. Can you also share some reflections on how and why pediatric medicine is implicated in this ruling?
Yeah, I'm happy to, and I'm so excited to be here amongst this group of amazing individuals. So I am a pediatrician, and I'm incredibly passionate about patient-centered care. And I want to piggyback a little bit on what Victoria said, because this Dobbs decision is a very scary precedent that is being set. It is taking decisions out of patients' hands and putting them at the state house. And while it is starting with abortion, it will not end there. It will start including many other facets of healthcare. And that's why you see organizations that you don't expect to be involved suddenly waking up. And I'm going to say the AAP is finally waking up and realizing that this is going to have implications in all forms of clinical care. You know, the Academy of Pediatrics believes in evidence-based medicine, and abortion is part of evidence-based healthcare. It's part of healthcare. There are many reasons why people need abortions, but it should always be available and accessible to people that desire them or need them. And then as a pediatrician, we have all these patients after they're born. And so I very much want every child in my practice to have been an intended, supported, and planned pregnancy. And what I can tell you is that is not the world we live in now. You know, close to 50%, if not over 50% of pregnancies are unintended. And so when I see a newborn in my office, I can't assume that that's always a happy moment for those parents. It can be a terrifying moment for them. It can be a very stressful moment for them. And so pediatricians absolutely need to be a part of this conversation, if it's not for the parents, but also for our patients as they are adolescents and young adults transitioning to adulthood. You know, we are seeing these attacks on healthcare decisions that will percolate into gender affirming care next, which is very much a pediatric issue and something that I think is a sign of this precedent that's going to start happening now that the Supreme Court has opened these floodgates in a legal opinion.
Thank you so much for sharing and for really making it plain how pediatrics plays a role in this. I think we hear pediatrics and we think, you know, small children, but forgetting that, you know, adolescents are also included in pediatric care. And so thank you for making that plain for us. Dr. Vernon, the American Society of Health System Pharmacists, in partnership with the American Medical Association, the American Pharmacists Association, and the National Community Pharmacists Association, expressed concerns about the impact of the ruling would have on limiting patients' access to medically necessary medications, as well as impede physicians and pharmacists from using their professional judgment, really to go back and underscore what Dr. Wilkinson just said. But more specifically, their joint statement stressed, and I quote, that physicians, pharmacists, and other healthcare professionals face a confusing legal landscape due to states' laws' lack of clarity, confusing language, and unknown implementation by regulatory and enforcement bodies. This includes many questions about how broadly state laws will be interpreted and the impact of these actions on physicians and pharmacists' ability to serve the needs of their patients. Physicians and pharmacists need clear guidance from state boards of medicine and pharmacy, agencies, and policymakers to support the prescribing and dispensing of medically necessary medications that may be affected by this new legal and regulatory paradigm. And without such guidance, we are deeply concerned that our patients will lose access to care and suffer irreparable harm. So in what ways do you share or not share the concerns of the ASHSP?
Thank you. Thank you for the opportunity to be here. This is a pharmacy issue. I think pharmacy organizations have avoided this conversation for many years. I think it's been uncomfortable, and a lot of individuals felt that Roe was never going to be overturned. And what we're seeing now is pharmacy organizations coming to the table because over half of abortions are medication abortions. And the FDA updated, the Food and Drug Administration updated how these medications can be dispensed in December. And currently the manufacturers have updated their requirements for their programs to dispense mifepristone, which is the first drug used in a 2-drug regimen. The second is misoprostol. And it would allow pharmacies to start dispensing mifepristone. Previously, we only saw this dispensed by a provider in a clinic setting or a hospital setting. And this is really changing it because the federal government has said the Food and Drug Administration, which is the governing body of what food, drugs, and cosmetics and medical devices are safe for use, has approved this 2-drug regimen for abortion and said this is a safe and effective for use. So as pharmacists, we're in an issue now where we have states saying, no, these drugs can't be used for an abortion and banning it. And then the federal government is saying, no, these can be used. You can't argue that this is a safe, these drugs aren't safe and effective to be used. And we're seeing comments come out now from the Office of Civil Rights through HHS, and we're seeing the U.S. Attorney General issue statements saying states cannot ban the safe and effective use of medications. And pharmacists are left in a predicament of, do you want to go to federal or state jail? Is really what it's coming down to. And it's incredibly frustrating because we want to be able to use our best professional judgment to care for every patient. And I'm incredibly passionate about making sure that patients have autonomy and are the ultimate decision makers in their healthcare. And it's making it really challenging because we're seeing in some states how they define what an abortifacient is or an abortion-inducing drug is not how the FDA defines it. They're coming up with their own definitions, and it's leading to issues where pharmacists are afraid to dispense any medication that could potentially be harmful if a patient were theoretically pregnant. So not even if they were pregnant, but because this individual could become pregnant and is taking a medication that could be harmful, they are concerned for dispensing. So we're seeing pharmacy corporations tell their pharmacists, you need to confirm what this medication indication is being used for before you dispense it. And that's leading to issues for patients getting access to medications, which is ultimately impacting their healthcare and their activities of daily living if they're not able to access some of these medications. We had a patient in Indiana who reached out because they were unable to get their ibuprofen filled because the pharmacist was worried about its potential impact if this patient were to become pregnant because they had the ability to become pregnant, which is not what our law says, but this is where we are right now. And I am glad to see pharmacy organizations stepping up and coming up with policies and how to guide pharmacists and guide public policy towards making sure that patients have control of their healthcare.
Yeah, thank you so much for sharing that, the pharmacy lens and how medication, one prescribing and dispensing, right? Just the amount of cognitive sort of gymnastics that has to happen because of the sort of lack of guidance and clarity around the language related to medication. And, you know, and to hear theoretically pregnant too, right? Just sort of the implication of that was really jarring to hear. And it also makes me think about, for occupational therapy specifically, because we really haven't heard OTs talk about sort of the real fear of going to jail over this, right? But what happens even in our prescribing of home exercise, or if you're using a particular physical agent modality or anything where pregnancy is contraindicated, how some unintended misstep, right, could potentially cost someone their license or even worse, jail time. And so, and this question is sort of broadly for any of you, just sort of in your personal practice, or how are you managing, sort of dealing with this, right? Sort of making these decisions, knowing that you may be dealing with a client who could be theoretically pregnant, right? To use sort of pharmacy language around that, and what the implications are for licensure.
I think for those of us who are in private practice, it has definitely caused us to edit like our contracts, that we have with patients or organizations that we work with, to be able to put in a non-fault clause, so just like, any surgeries, before you go surgery, these are the risks and you sign off on it. So it definitely has changed, I think, my contract as well. I actually had my girlfriend kind of look at all of my stuff just to make sure I'm covered. Because that is where we are, like you said, just because it's not intentional doesn't mean that you will not have to deal with whatever consequences or sanctions that are handed down as a result of this decision. And then it also influences, like whether or not you use certain treatment interventions, right? It's particularly when these interventions have been successful in the past. So now you're questioning, should you even use it? Therefore, you're also influencing the progress or even just the potential outcome of your client that you're working with. So it has definitely changed the way that I have practiced. It has definitely changed conversations that I have had with patients. And I consider myself to be very personable. But I feel like now I'm having to be stoic. I feel like I can't authentically be myself because I'm trying to make sure that I'm checking off all the boxes to cover myself in practice, while again making sure that I am still trying to provide, as Dr. Wilkinson said, that patient-centered care to those whom I work with. So it definitely has been a process of, like I said, just changing all of the language that is currently within my contracts that I have with individuals one-on-one, or maybe organizations that I may be contracting out with as well. And then also my liability insurance, right? I had to go back and have a conversation with them to ask, how has this influenced? So I'm actually waiting to hear back about that, like since the decision has been made, and should an occurrence happen that may result in me being sued, like, does my liability insurance covers this? And deciding whether I stay with that liability insurance or maybe I need to go shop around. So I'm hoping that I get some information and maybe share that with you all to be able to share with your audience as well. So these are definitely things I didn't think that I would have to consider, but here we are.
I would say for me, the work that I do with teens in recovery, I've had a lot of questions regarding, so some of the stipulations for exception after this abortion restrictive law had passed, which has now been repealed and kind of put on hold until January 1st in Indiana. But while there was this short period of time, I had a lot of teens ask me, we've heard a lot about health and life of a mother. That seems really physical, Dr. Wilburn. Like, we are struggling every day to journey on this road of recovery. And if we got pregnant right now, that would put my life at risk psychologically. And we just don't have any guidance on that. Like, how do we assess life of a mother and what quality of life of a mother, and who's defining that quality of life? And so those are questions that, have yet to be determined. How do you have a pulse, or how do you establish a caliber on the psychological health of a mother? And so that has been something that we've been having, circles about more about this access to the necessary access to birth control. But also, when we are faced with that decision, potentially, what are the first, second, and third order effects? Those are conversations we would have never had before. And I should note that, particularly here in Indiana, it's not just talking about abortion. They have made it known that the second and third order effects will be birth control, IVF, and surrogacy. So those are all issues that I think each one of us can intersect with on our daily lives. And it just feels like a very intimate decision and intrusion on how we can live our lives. So tying that back to occupational therapy and thinking about, who determines quality of life, what kind of quality of life can we engage in, and how do we keep a pulse on the psychological effects of well-being of a mother, and who determines that?
Dr. Wilkinson or Dr. Vernon, I guess any other comments related to, your licensure and sort of thinking through, especially you, Dr. Vernon, sort of the fear of, having your very best clinical judgment sort of landing you in prison, and thinking of, client-centeredness and best practices, and how that too sort of comes under assault under this ruling, and sort of the unintended consequences of that.
Yeah, I think you summed it up really well. That I think as pharmacists, we're really wondering, what should we be doing? Could I potentially have my license taken away or be disciplined by the Board of Pharmacy for dispensing a medication, and thinking that I was using my best professional judgment, but I didn't do what maybe another practitioner would do in the same situation. But both ways were correct based on our professional judgment, but we just did it a little differently. And I think that's something that's been really a challenge for us navigating being in Indiana. I know Dr. Wilburn and Dr. Wilkinson can speak for this too, that with the bill that has been put on hold that passed, pharmacists said, well, there's nothing in this bill that says pharmacists could be disciplined, but there's nothing in this bill that says we can't be disciplined. And because of the current state of our Attorney General's office in Indiana, it's a large concern on all healthcare practitioners' minds right now. Where do we go from here? Could a complaint be filed against my license that leads to legal action, that leads to me needing to hire legal counsel to defend me for doing something that was completely appropriate for the patient, and reaffirming what the patient desired and what was in their best interest. And so that's something we're trying to navigate as well. And Dr. Wilburn did a nice job touching on contraception being in the pipeline that we're all worried about. Pharmacists in over 20 states are prescribing contraception right now, and that's something that we'd love to see in Indiana, but it's a concern for us. We've had patients calling us all the time now, can I still get Plan B? Can I still get access to that? And seeing it go off the pharmacy shelves very quickly as soon as the Dobbs ruling came out, and then as states continue to pass more legislation post-Dobbs. But great question, and it's something that I think about every single day, multiple times a day.
Mm-hmm. Yeah, and I just wanted to piggyback that I think all of us are concerned about, a few years down the road, when people start really having decisions to move to other states come across their radar, and individuals in training that actually have the opportunity to move at the end of their training choosing not to stay in the states that they trained in, and what that will do to the healthcare landscape. We already have huge primary care access deserts in our state, long wait lists to see individuals like occupational therapists when you're outside of major metropolitan areas. And so when you start seeing practitioners move, how is that going to impact the communities that are left, in particularly the communities that are already struggling to get care because they don't have insurance or they're on Medicaid, so they can only access care in safety net settings. And so when you start to see a deficit of practitioners start moving out, it's just going to get worse. And so that's a concern I think all of us have, and that we tried to raise at the State House, that this is not a switch you can suddenly flip back and say, come back, like, you know, don't come back to Indiana. We changed our law. It takes a long time to grow infrastructure and people's trust to stay here and plant their roots in a city or a state. And if they don't feel that their bodily autonomy or that their human rights are respected, they might not choose to stay here, and I can't blame them.
Mm-hmm. Yeah, thank you for also mentioning that, the sort of the healthcare landscape and how this ruling has really affected how people decide where they live after graduation. And even bringing the point about, you know, access. I think sometimes our minds immediately go to rurality when we think about access deserts and where, you know, people can or cannot have, you know, whether it's pediatrics, gynecological care, or occupational therapy. And, you know, it really made me think about, like, you know, if I wanted to see an occupational therapist like Elle, like somebody who is really an expert in perinatal care, can I get that in Chapel Hill and Durham? I can't. And I live in a well-resourced area. Like, we are between 3 major universities, 2 university hospital systems. I can't get that here, you know. And imagine that once people are done with their training and choosing to move elsewhere, that, like you mentioned, the access issue is only going to amplify. So I know we sort of started our conversation talking about these statements, right? And how our professions have sort of positioned themselves, either, you know, of course, I believe neutrality is a myth, right? But sort of being a little bit neutral, or taking the ethics or moral practice standing in this particular work. And I'm just wondering for you all, sort of think about advocacy, right? So if you could really evaluate where your professions are now and how you see yourselves as individuals really moving the needle on healthcare for all, related to abortion or not.
I'm going to tee this story up for Dr. Wilkinson, actually. So Dr. Wilkinson and I met both waiting to testify on the abortion bill. And we serendipitously we were sitting next to each other. They allowed so many people in the chambers. And she made fun of me because I was drinking like a protein shake, you know, and so she was starting to jazz me. And I was like, oh, okay, she's safe. Like, you know, you just don't know who's coming to testify. And so we quickly became fast friends. But I want Dr. Wilkinson to talk a little bit about the amazing work that a new nonprofit in Indiana has started. It's called Good Trouble Coalition. And it is a multidisciplinary nonprofit that really centers around advocacy. So I would love for her to explain more on how you can potentially start Good Trouble in your state.
Yes. So, you know, Indiana was the first state to propose an abortion ban after the Supreme Court decision. And so we had this special session in the summer, and all of a sudden, a lot of people in the healthcare fields, you know, realized how big a deal this was and wanted to get involved. And people from all different fields in medicine and public health, but they didn't have like a home base. And so we started realizing, like, well, rather than creating, you know, like a reproductive task force in every single one of these professional organizations that we can't even trust that professional organizations will eventually represent our views, we're just going to start our own. And so we started the Good Trouble Coalition, which is after, you know, that amazing quote that I'm totally going to mess up, so I won't even try. But, you know, saying that you have to make some good trouble to create change. And so we had a letter and we just sent out an email blast, social media blast, and had 1,800 people in Indiana sign on to this letter about reproductive rights to show the State House that clinicians and healthcare practitioners were watching and that we did not believe that this was in the best interest for our patients. And it was incredibly powerful to say that, like, we weren't all pediatricians, we weren't all OBGYNs, we were everybody. We were physical therapists, occupational therapists, social workers, you know, physicians, PhD, public health people. And so it was powerful. We hope we're going to continue to cause trouble at the State House, to let them know that we are watching. Indiana has got a Supreme Court case right now that is going to impact potentially ability for anybody to sue public institutions for care that they receive. And so the Good Trouble Coalition is working with other organizations to try to activate people to start paying attention, right? Nobody usually pays attention to these little stories, but it turns out that these legal cases are having huge ramifications for our patients and the most vulnerable patients. And so if we don't stand up and say something, nobody else will. And the legislatures are making these decisions about how we practice and how we take care of our patients. And we have to say, like, we have to have a say in that conversation. And so that's, yeah, I reach out if anybody's interested. We're trying to have like sister chapters all over the country. And I'll put the website in the chat if you want to check it out.
Thank you. Thank you for doing that. Before we start fielding questions and comments from the chat, I'm going to go off script just a hair, so you all didn't prepare for this one, but so it was brought to our attention, like a comment that was shared on social media about a week ago related to sort of pro-lifers, right? Anti-abortion folks. And I personally would argue that everybody who, you know, advocates for abortion as healthcare are also pro-life, right? Like we are sort of have special considerations for healthcare practices and really what that means broadly, you know, not conceptualizing abortion as a form of birth control or these other sort of like perverted interpretations about abortion that gets circulated in popular media. And so I'm just wondering if you all could speak to or share a little bit about how you think about or reconcile in your minds sort of being abortion advocates, but as abortion advocates also supporting life.
I'll start. I never call the other side pro-life because that's giving them credit for something for which they are not. And so I only call them anti-abortion activists. And I refuse to play into that messaging when every other piece of their platform is the antithesis of supporting people, communities, and life. And so I try never to use the term pro-life because I do think it's a messaging genius on the other side. And I call them, you know, anti-abortion. And if I'm very upset, anti-abortion extremists.
Thank you, and that is an important distinction for everybody to consider. So thank you for sharing. Any of our other panelists feel they can share?
I think for me, just fundamentally, when it comes to our healthcare choices, like that's none of my business, you know, and regardless of how I feel, like I'm never going to impose my personal thoughts, feelings, and beliefs, because whether I'm talking about abortion, as healthcare practitioners, we encounter and engage patients all the time who have different health beliefs than we do, who have different lifestyles that we do, but we took these oaths to be healthcare practitioners to serve them regardless of what our own personal health beliefs, thoughts, and feelings are. So that's one. I mean, I don't care in terms of enough to try to inundate my thoughts and feelings about a person's decision, one. Two, also, I'm just looking at maternal mortality rates here in the US, right? And research shows that abortion, you know, increases that by 14 times. I'm sorry. childbirth is 14 times a higher risk maternal mortality than abortion. And as we have these different acts that are put up in terms of funding and putting resources together to reduce maternal mortality rates, it's really going to be interesting to see how this decision is going to influence that, particularly as the US, like we are a high industrialized country, yet we lead this, the rate in maternal mortality. And so those are two things that I kind of look at in terms of how I am able to be in this space and support those who make the decision to consider abortion as part of their healthcare choices. So that is what I use. Like I said, I'm definitely interested in these maternal mortality rates, particularly as it relates to women of color, because we already have the highest maternal mortality rate as well. And when we look at access to healthcare and equitable access to healthcare, we continue to be part of that marginalized community where we have the highest disparity gap in healthcare. So those are the two things that I kind of use to kind of influence my decision and guide my clinical practice and encounter with individuals who are considering abortion as part of their healthcare decision.
This is a little snarky, but those of you that know me personally know I have just a little bit of that in me. So when I engage with voters that might not be pro-choice, one of the first questions that people tend to ask me that are anti-abortion will say, well, are you pro-life? And my response is yes. I completely believe in feeding the poor and clothing the needy and taking care of all of those who are marginalized. And they look at me and they're like, no, I'm talking about abortion. Oh, you're talking specifically about abortion. And so I think it's just disrupting that myth. Like Tracy had said, that this is nothing about life. In Indiana here, there's 33 of our 92 counties that don't even have access to a maternity and OBGYN care. And there was a rebuttal that was back to that point. We said, well, actually, we might not have these OB, units in every county, but they're a 30-minute drive. Well, that's assuming people have transportation. That's assuming people have a way to get 30 minutes away. And 30 minutes can be life or death for you when you're bleeding, when you have an ectopic pregnancy, when you're hemorrhaging, when all of these things. And so there's just this assumption that, being anti-choice is somehow better. And in fact, it's 10 times worse. So I think we have to push that narrative, keep pushing that narrative back, like Dr. Wilkinson said, because it then exposes, how really anti-life the other view is.
I completely agree. These are some fantastic comments, and I'm just beaming because this is all great comments. And I think what I use, I work with students, I work with legislators, I work with other healthcare professionals, is what do you support that actually helps promote someone to have a fulfilled life? Are you supporting pregnancy accommodations? Are you supporting pre-K programs? Are you supporting subsidized childcare? Are you supporting transportation programs in your communities? And the answer is usually no against those things. And if we are not supporting a strong infrastructure to support all people to live their best lives, what are we doing? And that tends to be, I find, a strong argument that we are all taught in our education to respect the autonomy of the patient. And so why are we singling out this issue where we say it's okay to not respect your patient's desires with abortion?
Yeah, I think that is a wonderful note to end our more structured conversation on, is that if we're not in the business of supporting people to live their best lives, then what are we doing? So thank you for that. We have probably 18 minutes for questions from the chat before we do sort of announcements and closing remarks. So our first question is, how can people access more information on understanding fertility? So fertility, awareness method and out of the clinic options for womb care or various types of pregnancy relief abortion. Sorry, let's scroll down. How does fertility awareness allow us to increase autonomy over our reproductive health choices across the womb continuum? And I think I saw Dr. Veronica really like nodding head and clapping about that. Would you like to speak to that first?
Yes, I'd like to say as a pharmacist, I am all about fertility awareness-based methods and just teaching about fertility awareness because it is crucial to everything else. That the lack of education and formal education that people get in the US about their bodies and how they work is abysmal. And that needs to be changed. And I think somebody highlighted a good resource in the chat. But I think this is there. I think the issue is there are so few patient-facing publicly available resources out there that if you go to the CDC website, it's pretty scant on what they have. But I think that's something that you are all in a great position to help teach patients about this and about their bodies. And I think it's really important when we talk about reproductive justice that we're not just talking about access to birth control options that you can get at the pharmacy or from a prescriber's office, but what works for that patient in that stage of life and where they are. And I think that's really important. I'd like to hear from our other colleagues about what resources you use. I have had to seek out additional training to be better informed in this because this is not something that was highlighted in pharmacy school. And I think that's important. So, oh, great. Wonderful. There is a resource here in the call. So I want to open it up to those of you who are experts. But I think it's important to know, like Natural Cycles was the first app approved for fertility awareness. And I have recommended that to a lot of folks. I think that was really exciting and a good move by the Food and Drug Administration.
I put the link to that app in the chat, Veronica, because that's the one that I recommend also.
Thank you all. I'm going to wait a second. Even if there's anybody on the call, if you want to use the raise hand feature, I'll wait a couple seconds on that.
So while we wait, Kalila, I wanted to just circle back when you asked about our respective organizations and the work that needs to be done. I love my organization. I love being an occupational therapist. I love AOTA. I love supporting as a member in good financial standing. But I will say we have a lot of work to do here. And I'm hoping that it won't be a long road, but it definitely is a lot of work that needs to be done because we're just now, I think, are starting to accept and better understand and find support within our own organization just about our role in supporting women's health, right, overall. So now we talk about reproductive health and including abortion. I think that's a conversation that we haven't had just yet, and I'm really unsure if some of us are really ready for it, but it definitely needs to happen. And I'm hoping with the leadership that we have right now that, you know, we can start having these conversations at not only the state level, but also at our national level as well. And so I am hoping to be a part of that conversation or support that conversation as well, because it can be uncomfortable, right? Because that is not what our history is rooted in as a profession. Reproductive health, even though it is linked to mental health, which is what our profession was birthed out of. But I'm hoping that we continue. I love the statement that our president put out. So I'm hoping that we can continue to have these conversations so that we can discuss how we can better situate ourselves in this fight and also better support our other colleagues who are in primary care practice. So like Dr. Wilkerson, our pharmacy friends, as well, because we definitely have a role that we can play here, and a role we can really truly provide that wraparound services for birthing individuals, whether they have decided to go forth and have an abortion, or maybe carry the pregnancy to full term, whether it's intended or unintended. There's always some psychosocial ramifications regarding the decisions, and we have a very important role that we could play in terms of filling the gaps that's within our healthcare system, if we really are truly to provide wraparound services regarding this topic, and just women's health overall and birthing bodies' health overall. So I'm looking forward to see what AOTA does with this, and definitely here to help any way that I can.
Yeah, I appreciate you sharing that so much. And for people who know me and personally and know my work in occupational science and occupational therapy, I definitely echo the road we are on in the profession, and the social reckoning that we're having of really understanding the situatedness of occupational therapy in healthcare, and how we at times can perpetuate a lot of the problematic issues that happen within the healthcare system. So calling the profession in to really hold a mirror to itself and do the necessary work, and not just in occupational therapy, right? But we've also heard from Dr. Wilkinson about the AAP, and also our pharmacy associations, and a few others that I know that I follow personally on Twitter, about sort of calling everybody in to say, like, all right, y'all, we can't bury our heads in the sand about this. This touches all of us. It touches all of us. So another question in the chat is, oh gosh, see, this is why, y'all, I don't like using the chat because I don't know how to scroll. But there was a question in the chat about students and educating students around this and resources about that. In fact, the person who typed that in the chat, if you could just please unmute and state your question for us.
Hi, I asked the question. Also, all of you are so amazing, and it makes me so excited to be a OT one day. It makes grad school less difficult, I guess, right now. But I just wanted to know, attending a school in the South with some, differing views, and I think this is a very important topic, and I've tried to bring it up a few times, but there's some resistance against kind of informing the rest of the cohort or the program. So I was wondering if there were any ways that we could approach this in a positive way and kind of just go from like a healthcare OT I don't know, like another way to kind of frame it to get this information out.
I will respond to this one. There's nothing polarizing about abortion. Abortion is healthcare, and occupational therapy programs need to embrace. I mean, if you haven't already embraced that, then we need to really encourage our academic programs to embrace that. My students, I see a few of them on, we had a whole guest lecture on abortion legislation, all of it, and how they could get involved, because it really is, as we opened up this conversation, it's the first of many steps that we'll see an intrusion, a governmental intrusion in healthcare. And so just as we would, present any issue, we have to go back and remind those that are instructing us about occupational therapy practice that this is a part of healthcare practice, and actually it affects everyday life and participation, just like anything else. So if you want some resources, I would love to be able to provide that, or ways to which you could delicately have these conversations, but this should not be a polarizing issue.
Yeah, I wanted to piggyback on what Victoria just said. I think framing it also in the perspective of evidence-based and comprehensive education could help. I don't want to talk politics at school. And a lot of times people are like, well, I don't want to get into politics. And I was like, me either. I actually don't want this to be a political issue. It's just evidence-based medicine. So this is not political if you frame it in this idea of like, wanting to be trained in comprehensive care that is evidence-based for your future patients and your ability to be competitive on a job market. If you want to, be able to apply for jobs anywhere in the country, you can't be like, oh, I've been trained in everything but this. And so I would say, as a customer at that school, that's kind of your right to say that should be part of your education and training. I wouldn't go get my tires changed and just changed 3 of them. That's just I just feel like we constantly let this piece of healthcare be quarantined off, and it's unacceptable, and it never should have been that way. But the more we allow it to be a part of a different conversation, the more we play into the other side. And so I just think we need to keep pulling it back in. This is not women's healthcare, it's healthcare, period. And it's evidence-based.
I like that reframing. And if there are any students that approach their professors about including this as a part of the curriculum, please share it with COTAD about how you did that and the outcome. Be very, very interested to hear how that's going. But as a professor, in fact, the majority of us participating in this panel are in academia in some way. One of the first things that comes to mind is, we, even in our education training as practitioners, right, but also thinking about sort of the pedagogy that we learn, really understanding curriculum design and the standards that we are held by for educational programs. This kind of thing doesn't come up really. It's not something that is on our radar until we're really forced to think about it. And so that is, I think, another area of work that we have to consider. What is ACOTE, the Accreditation Council on Occupational Therapy Education, also the Accreditation Councils for Medical Education and Pharmacy Education. How are they thinking about this in terms of better preparing our students, even if they don't know the ins and outs of every single thing, but how to think critically around them, right? And really understanding how legislation directly impacts how we practice. And I know there were several other questions in the chat related to students and education. So I hope this last question and answer session helped you sort of get some information about the questions that you had. But I want to move on to this question we received about centering clients who will be disproportionately and negatively affected by DOS, how to center those groups, and some that were named specifically for BIPOC, so Black, Indigenous, and people of color, LGBTQ plus folks. And to go back earlier in the conversation, Dr. Megan Blaskowitz, not to put you on blast, but put you on blast, make sure to call attention to the fact that people with intellectual and developmental disabilities are also disproportionately impacted. And even in our conversation tonight, I don't think we've touched on people with disabilities enough in understanding how this ruling impacts that community as well. Anybody care to speak to that, sort of centering how to best center clients who fall into these minoritized groups?
I think making yourself available on whether it's certain committees, certain boards, making sure that you are speaking up for those communities, particularly when they're not being mentioned. I live in Stafford, Virginia, and I feel like I'm in a weird space here in Virginia because I'm in between DC and Richmond. And when we think of the socioeconomic makeup, we're like a hodgepodge. I can literally be here and you have a higher socioeconomic area, and literally 5 minutes down the road, we start seeing it go down, and then you go a little bit further and it kind of picks back up. But I always make sure that I am a voice for those individuals. I am also following up because I feel like most healthcare systems, they have these policies that are out there just to be out there to say that, hey, we're listening and we put these things in place. But when they're not following those policies, what sanctions are actually happening? What is being imposed? Are you following up? Are you rectifying problems? How are you handling, your community when they come in and they say, hey, I feel like I'm not being represented, heard, services are being made available. Are you hushing them up, or are you actually listening to them to make sure that you are extending those services and making it equitable for them. So I find myself just being that voice at the table for those individuals. And even if that means that I'm standing in silo, so let it be, right? Because I have to realize that I have come from a place of privilege, right? And it's easy for us who have come from a place of privilege sometimes to not consider those who may not have, you know, because it's not impacting me. So why do I need to say anything? But at some point, if you don't speak up, it will impact you. So that's sort of how I kind of make sure that I am centering those voices. I am also looking at the makeup and the representation of those who are making the decisions, because how can you truly represent and center those people when you don't have them at the table as part of the decision-making process? So sometimes we have to question and shake up that tree of leadership as well. And again, don't be afraid, you know, to ask those questions, even if it's going to be some pushback that comes against it. So that's sort of like the path that I take and how I kind of approach making sure that those who are considered marginalized, you know, are being considered and centered when it comes to our healthcare practice.
Thank you so much, Elle, for sharing that. Also want to take a moment to recognize there are two hands that have been raised. Jordan, I believe, and Atchie. And allow you 2 minutes each to speak, and that will give our panelists also some time to respond if it's a question before we have to end our Q&A.
Hi, I wanted to ask a question specifically to Elle and also to Dr. Wilkinson, just regarding, like, I know we talked a little bit about contraceptives and kind of talking to these populations about, like, you know, those kinds of options, but I'm also wondering, because there's significant evidence, especially for like chronic illnesses, about like preconception education and that kind of like programming. So Elle, I guess my question for you is, how do you incorporate that into your discussions? Because I know you're kind of dealing with people that are already pregnant or postpartum. But then Dr. Wilkinson, with your population as a pediatrician, like, do you have those conversations? When do you have those conversations? And are they conversations that need to be approved by like a parent before you have them? So just kind of wondering how that works out.
I'm going to let you go first.
So, well, I would say the population that I work with are 18 and older. So I am not interacting with anyone who may need parental advice. I really don't have preconception service as part of my care, but I do have practitioners who particularly work in the area of preconception. So I will refer patients to them or potential clients, and, you know, hopefully after they made their decision and they decide they want to get pregnant, then I see them afterwards. So that is not a conversation that I have, but I do make sure that I have resources available, because I understand that you will sometimes be seen as a subject matter expert on everything, even if you're not practicing in that particular area. So unfortunately, that is not a conversation that I have, but I do have resources and individuals with whom I can refer them to.
Yeah, so I talk about this with every single patient, and I use the PATH questions. Do you think you might want to be a parent one day? When do you think that is? And how important is it for you to prevent pregnancy or parenting until that moment? These are very, they're validated patient-centered questions, and they open up an amazing conversation with people, regardless of how old they are, how they identify in terms of sexual orientation. And so I use those for every single patient, as well as parents that come in. Every state's a little different, but there are a lot of protections around having private conversations with patients. And so I tend to, you know, ask parents to leave so that I'm able to ask questions about a whole host of things: school, home, hobbies, friends, but also kind of their personal life. And so I think it is really important to be asking these questions at all times. And I'll put some links into the chat about the PATH questions that I just mentioned. And then I highly recommend the website amaze.org, which is very human-centered, designed by young people. It's like more information on sex ed, but less awkwardness. That's like their tagline. But really great information out there, because shocking, not shocking, there is very little consistency as to like the comprehensiveness of sex education that's going on for our young people in our country. Many states have like laws that say it doesn't have to be medically accurate, and a lot of states have to emphasize abstinence only. And so, you know, assuming that young people have adequate or accurate information is not a great assumption.
Thank you both very much. And Achi, this will be our last question and comment for the evening.
Hey everyone, thanks so much for just opening this dialogue in the OT community. I mean, it's so important, and I'm super stoked to see this happening in the OT world. I just wanted to sort of open up the thought to folks around that we, although it's so important that like legislation and everything like in the legal sphere of abortion is like that we make progress there and that abortion becomes fully legal. Also, it's so important that we all just educate ourselves as much as possible on how to be our own providers, and that any person in this room has the ability to learn how to support other folks through having abortions out of clinic through various methods. And I know that that's potentially a new idea for some folks in this room, but I think it's super important because at the end of the day, the government doesn't care about us, and we do. And so I just, wanted to drop that little nugget in case folks want to start thinking about that. And also I had just a quick note on like the difference between natural cycles and fertility awareness method. And I'm not going to spend a lot of time on it. And feel free to reach out to me anytime, anybody in this room. But natural cycles uses an algorithm to predict your fertility based on past cycles. And this has inaccuracies sometimes, just like literally any form of contraception. And so that's why it's super, and I think of it as like, at some point I was in a codependent relationship with the government and my doctor in order to access contraception. And at another point I was in a codependent relationship with an algorithm to determine my fertility. And it's just a huge step towards even more empowerment and body literacy to actually be fully informed yourself about your in real-time fertility, which is the main difference between using an algorithm like Natural Cycles or DAISY and actually using a fertility awareness-based method, which there are many. So, awareness of timing, if conception does happen, can happen before literally like a pregnancy test sometimes, and definitely before you would be recommended to go into a medical office. And you just have so many more options for taking care of yourself if you have more body literacy around your own reproductive health. So I just wanted to drop that in. And folks can reach out to me anytime if there's more questions, because I know we're kind of done here. I'll drop my stuff in the chat.
Thank you. Yeah, I was just about to say, make sure you leave your contact information in the chat for everybody. So again, thank you all. We probably need to do a part 2 about this. I mean, just another hour and a half on really unpacking these resources. You all have really provided so much information just in the chat. And so just I can't thank you enough for being willing to put yourselves out there and sharing knowledge, because that is what we are here to do. And thank you again to our amazing panelists for your time and your expertise and just giving of yourselves for our learning this evening. Y'all don't log off yet. I see that participant number going down. So I'm actually going to share my screen again because we have some announcements to share before we adjourn officially this evening. So want to go back to the screen. All right, so announcements, Whitney.
Yeah, thank you. Awesome conversation. I have also been working diligently to make like a quick resource list. So I'm hoping I'm not missing anything, but I'm going to try to throw it in the chat so everyone can see. I think I got everything that might have been in the chat. So yeah, hold on. Don't go anywhere yet. I'm going to share it. But announcements. So we've got a few things that are just amazing that COTAD has been working on. First and foremost, we have Book Plus Club in November. This will be the last book club discussion of this year. So we would love for y'all to join. This is so unlike tonight, it's a little bit more informal and just discussion based. But we will be talking about linking anti-racist action from the classroom to practice. And we will have Dr. Selena Washington and, of course, our very own Dr. Kalila Johnson, who is awesome because, I mean, you saw how great she moderated tonight. So join us for that discussion on November 16th at 6 p.m. Central Time. There is a link and it's open now if y'all want to go and just sign up right away because you just cannot wait. I'm going to put that link in here real quick. So you can go and sign up, join us. We'd love to have you. Read the article and we'll chat about it. The next one is that our strategic plan is on the COTAD website. So we have been working very hard this past year. We've been a little quiet, I feel like, on social media and everything because a lot of our energy has been going into the strategic plan. And this is really, we talked with COTAD membership. We asked what people were feeling like they needed and wanted from COTAD and we put up a plan and it's there for everyone to see and really take a look and dive into what we will be working on in the next 5 years. And last, but very much so not least, we have our 10-year anniversary coming up this upcoming year. So COTAD has been around for 10 years already and we're so, I don't know, just excited and grateful for all of the members and everyone that's worked so hard to make COTAD what it is now. So there will be more details coming soon, but we are going to be celebrating all year next year with events and celebrations and resources and panels and everything. So stay tuned. All right. Thank you. And to Kalila, I think, or Dr. A.
Yeah, and so closing remarks from our fearless leader, Dr. Anne-Marie and our panelists.
Yes, well, this was incredible. Again, thank you for moderating. Thank you, Whitney. Thank you for organizing COTAD Engage. Thank you to the panelists and the incredible participants. The chat was off the chain. It was so great. I couldn't even keep up. So I'll keep these very, very quick. OT is political. OT is community. OT is belonging. OT is vocal. OT is a force. OT is front and center. Discussions like this are critical in reiterating the influence we have as a profession when decisions like these are made in healthcare. As we listened, engaged, learned, and processed the discussion this evening, my hope is that we can continue to utilize our voice boldly and courageously in spaces that directly affect the populations we serve. This is clearly not just an OT issue, but an everyone issue, an interdisciplinary issue, and I am thankful that we have created space to have dialogue about ways we can continue to get into good trouble. So I want to also give space to our panelists to share any of their closing thoughts as well.
I'm just in awe of you guys, and I can't believe you've been doing this for 10 years. Veronica and I have been like texting about how jealous we are that you have this organization within your professional like space, because we are very envious and wish we had like anything like this to join in our own spaces.
You all can join COTAD.
I mean, yeah, can we have an honorary membership?
Yeah,
come on over.
Come on over. It's really been an honor to be here, so thank you for inviting me.
Thank you so much. I echo Tracy's comments. You are an incredible group of individuals, and I am just in awe. I have loved my time here. Thank you so much. I've loved how engaged you've all been and the great questions and how you all help and support each other and lift each other up. And thank you. This is wonderful.
Thank you. Thank you both for accepting the invitation.
This has been great. I always feel like I'm coming back home whenever I have an opportunity to support a COTAD event. Dr. Wilkerson, I'm really going to be in touch because I want to discuss further how we can set up that Good Trouble Sister organization here in Virginia. So I will definitely be in touch as well. So thank you once again for the opportunity.
I want to close by saying thank you too. I love seeing my sisters shine in their spaces. It's just so beautiful. And it feels like we have like a family reunion here of family members that you never met before. My note of encouragement to each one of you is if you don't like who's representing you, vote them out. So please, 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 please don't forget to vote this midterm election. It is one of the most critical elections in our lifetime, November 8th. It's too late in most of our states to check your voter registration status, but please, if you are a registered voter, get out to vote, find your polling place, and look up candidates who are like-minded to what you cherish and what you want to see in this world.
All right, thank you all so much. Thank you again to everyone who joined us tonight. I know some of you all weren't even off work yet, so we appreciate you. And for the folks who are like me that probably have little ones that need to go to bed, just thank you all for staying up with us, and be on the lookout for the resources. We'll also share those on our socials and an announcement about accessing the recording. So panelists, if y'all can hang off for just another minute, Dr. Ansbury, you as well. And we bid you all good night.
Don't you know, talking about a revolution sounds Don't you know, talking about a revolution sounds like a whisper while they're standing in the welfare lines, crying at the doorsteps of those
Perhaps we can stop recording and remove.
wasting time in the unemployment lines.